All right, I guess we're recording. Can you wave at me that we are? Okay. Good evening, everyone. Welcome to the Miracle of Living. My name is Frank Miles. I'm a community member of the Miracle of Living Planning Committee, and I'll be your moderator this evening. The title of our program is Why Can't I Sleep? My Sleep is Not What It Used to Be. We have two speakers. Our second speaker has requested that he be introduced before he speaks rather than right now, so I'll simply tell you now about our first speaker. Our first speaker is Dr. Deepti Chandran. She received her medical degree from Wright State University in Dayton, Ohio, completed her internal medicine residency at UC San Francisco Alameda County Medical Center. After this, she completed a fellowship in sleep medicine at Stanford Sleep Disorders Clinic, which is one of the most prestigious sleep programs in the country. In addition to her board certification in internal medicine, she received board certification in sleep medicine in 2011. She has clinical interests in sleep-disordered breathing, circadian rhythm disorders, and pediatric sleep disorders. In her spare time, she enjoys exercising and spending quality time with her two small kids. Please welcome Dr. Chandran.
Hello, everybody. Thanks for coming. So, why can't I sleep? This is a common problem, and I'm sure you guys all want a little bit more information about this, so I'll just go ahead and get started. I'll kind of give a background on sleep and aging. And how does sleep change as we age? Do we need less sleep as we get older? As we age, does sleep affect our overall health and medical conditions? And in the end, the final take-home point is really what can we do to get good sleep? That's kind of my main focus. So in general, why do we need to sleep? Sleep is essential for our overall health and well-being. It's just as important as nutrition, just as important as exercise. And so we really need to get good rest to be able to cognitively and physically function and live productive lives. So in order to understand sleep, we need to understand that normal sleep, there's an internal clock, and normal sleep and aging works together with our internal clock. So we have a biological clock in the brain, and it helps regulate when we're sleepy, when we're alert. And it works in tandem with our schedules, with the light schedules, with our feeding schedules, with our body temperature, and with our hormones. So as things change, of course, our sleep is going to be affected. And things, of course, change as we get older physiologically. So one of the things I want to show you on this chart is just, if you notice, the blue areas is our area of REM sleep. That's our deep sleep. And you see when we're young children, we get more REM sleep. And as we get older, we tend to get more broken sleep and less REM sleep. So sleep conditions tend to worsen as we get older. And also with age, we get more sensitive to hormone changes. Physiologic conditions, we're more sensitive to the lights, to the noises, to the temperature. So keeping up a really good sleep hygiene routine becomes key because we have all of these other natural factors kind of going against us. So we have to be very vigilant about keeping good sleep hygiene. On this chart, I talk about normal sleep and normal aging and our sleep efficacy. So sleep efficacy is a way of just saying how much time do we actually sleep versus how much time we're in bed. So as you get older, you can see there's definitely a downtrend. Our sleep efficacy reduces as we get older. So the take home is that the ability to get continuous and consolidated sleep may become more difficult as we get older. And sleep problems become more prevalent as we get older. The biggest things I always hear about is the snoring issue and mainly the insomnia issue. That's really one of the most common complaints. As you can see the trend, insomnia complaints tend to get higher as we go into older ages. So what is insomnia? It's a difficulty falling asleep, frequent awakenings, waking up too early, having difficulty falling back asleep. you feel unfreshed, and 48%, so half of the population, suffers from insomnia. And it has next day consequences. So people need to be able to function. So insomnia is a really big thing in sleep medicine. And how do we treat it? So, like I said, it's going to be more common as you get older. We really have to be on top of those healthy sleep habits, behavioral therapy. We can use prescription hypnotic medicines. I don't like to have them on chronically, but we can use that as an adjunct to our behavioral therapy. Really, the mainstay is fixing our behaviors and having good hygiene. So how many of you guys have done this? Yeah, this clock watching, kind of getting anxiety, saying, oh, I got to get up at 6 o'clock in the morning, and it just makes us more and more stressed out. This is what not to do. So our mainstay is something called cognitive behavioral therapy. Cognitive behavioral therapy is a structured program that helps you identify and replace thoughts and behaviors that cause or worsen sleep habits. So we have to get to the point of what's causing the sleep and kind of stop those thoughts and behaviors. And it's a multi-component regimen. There's many different parts. The top two are probably the most significant. It's the sleep restriction to create a sleep debt so you can fall asleep quicker. Stimulus control, such as lighting, TVs, all of that before you go to bed. Cognitive therapy, changing your thoughts about sleep. Sleep hygiene, and relaxation training. And our goal is to alter the factors that are presumed to sustain the insomnia. We have to break that behavior. And this is the frontline treatment for chronic insomnia. I'll brush briefly upon snoring. This is another common complaint as you get older, and Dr. Eltawil will talk more about this. But, it's a blockage of the airway causing abnormal breathing. And the people that are most at risk are males, those who are overweight that have a large neck size. And loud snoring can be a sign of sleep apnea. Same with sleep apnea, the other most common thing. It increases as we age, and it's pauses and gaps in breathing due to obstruction in the airway. Its main signs are the loud, regular snoring, the large neck size, the obesity, but it definitely can. It's way more common than you think, believe it or not. It can present even in, I see it oftentimes in like a postmenopausal female. Things are changing, the tissues are getting saggier. You don't have to be that same stereotype of the overweight, thick-necked male. And the most efficacious treatment option is positive pressure therapy, or CPAP. And we have a lot of vendors in the back that I'm sure would be happy to educate you more about positive pressure therapy. So this is just a blockage in the airway. Restless leg syndrome, again, I'm going to defer to Dr. Eltawil. The jittery legs, you can see that. It's just involuntary urge to move the legs, and it's worsened by iron deficiency, renal disorders, and pregnancy. But again, we're going to talk more about that later. So what else affects our sleep? In general, medical conditions increase with age, right? And medical conditions that increase with age are associated with sleep problems. So there's so many medical conditions: hypertension, heart disease, stroke, menopause, cancer, all of these things, depression, Alzheimer's, arthritis, all of these things can affect your sleep. And what do we do to treat it? We give medications. And what do those medications do? They sometimes cause sleep problems. So it's very important for when you get an evaluation to have a very thorough look at your medication list to see if any of these things can be worsening your sleep problem. So it's important to kind of get a full opinion of your full picture. Other things that can affect sleep: alcohol, nicotine, caffeine affects sleep. I want to point out the alcohol because sometimes I hear patients say, I drink a glass of wine to help me sleep. Which sure, it can help you fall asleep sooner, but your quality of sleep becomes worse as through the night. So you end up feeling less rested in the end. So I want to point that out, that that's not a good habit to help you fall asleep. So this is my main point of this talk, is sleep tips. What can you do? What can you do to help yourself get good sleep? So establish a regular schedule with consistent bed and wake times. Maintain a very relaxing bedtime. Create an environment promoting sleep, quiet, cool. Go to bed at the same time every day, like I stated. Your body clock really works best if it has a routine. On average, an adult needs 7 to 9 hours sleep, but that's just an average. Different people need less, different people need more. And use naps wisely, no longer than 30 minutes. Your sleep is like a bank. So if you're getting in a 1.5 hour nap, you've taken away that sleep debt. And so your drive to fall asleep later in the evening, when it's actually sleeping time, will become less. So if you use up that bank of sleep, you won't be able to fall asleep. Help your sleep-wake cycle. So if you remember back in my earlier slides, I talked about the brain and kind of the internal clock. The daylight, the light, helps regulate your sleep-wake cycle. So spend time in the daytime outside while it's daylight. Ensure your work and home environment gets lots of daylight during the day. Promote melatonin secretion by, when it's time to sleep, turn off your bright lights, turn off your TV, turn off the cell phones, the electronic devices. Thank you. Thank you so much. That light in your eyes will wake you up. And if you do get up at night, try to use dim lights. Remember your bedroom environment. A lot of people use their bedroom essentially as a workplace, sitting on their laptops, doing whatever they need to do, responding to emails. Your bed is for sleeping in intimacy only. TVs, computers, mobile phones, tablets, work should all be left outside the bedroom. Ensure you have comfortable bedding and room temperature, and keep your room temperature cool. Try to eliminate noise and make sure your room is dark. And you should not be lounging in your bedroom. Lounge somewhere else, come into your bedroom when it's time to sleep. Things to avoid. Avoid big meals before bed. Avoid alcohol and caffeine. Avoid napping on the couch in the evening. This is something my mom does all the time. Why can't I sleep? I come home from work, I have dinner, and then I fall asleep on the couch. So avoid strenuous exercise late in the evening. Quit smoking and don't clock watch. Don't get stressed out about the fact that you haven't fallen asleep yet. And what if I can't sleep? So sometimes that happens. You can't force yourself to fall asleep. But things you can do. An hour before bed, try to unwind, read, take a warm bath, listen to relaxing music, stretch, do relaxation exercises. Try to sort out the day's worries before you go to bed. Write down solutions to the problems. And if you're not asleep within 20 minutes, get out of bed. Go to the other room. Remember, we don't want to sit in bed wondering why we're not sleeping. Sit quietly in a dim light and come back to bed when you feel like you're getting tired. Totally normal to wake up a few times in the middle of the night. If you can't go back to sleep, try to remain relaxed. Try to not be anxious about it. Sometimes having a notebook by your bed and writing down thoughts and solutions to problems, sort out those things during the day. Sorry, I have a little rough throat. Keep a sleep diary. Write down, you'll be surprised how many times we have patterns. The patient gets up at 2:30 every morning or 3 o'clock in the morning and then does this and then does this, and have a sleep physician come and review it. Sometimes just having a third party look at your medicines, look at your habits, look at what you're doing. You don't even realize some of these behaviors are so internal to yourself unless someone's kind of looking on the outside and taking a look in onto your life. So let's talk a little bit about sleep studies. A sleep study, so you finally decide, I want to go get evaluated. The sleep physician may tell you, you need to get a sleep study. There's different kinds of sleep studies: diagnostic, PAP, or split night. This is what it looks like when you get a sleep study. Don't be scared, but we have to get some information. You'll see a nose cannula, some wires, and some leads. So, we try to not make it as obtrusive, but this is what it looks like. Kids sometimes get sleep studies. I won't talk too much about pediatric sleep apnea. I'm very interested in it, but it is kind of a side topic. But yeah, kids can get sleep studies. I've sent my kids for sleep studies. And we have our sleep center at Torrance Memorial. And I'm not sure if you guys know about it, but if you don't, definitely, if you feel like you need a sleep study, you're welcome to ask your doctor for a referral. This is what our lab looks like. It's really nice. This is us. This is my handsome sleep tech, Patrick. And we're evaluating our patient. We're looking over some sleep studies. We have, these are our computers. You can see this is the data that comes up from the sleep study from those wires. And it really gives us a lot of information. We know how your chest is moving, your heart, the brain leads. We know how your brain is functioning. So it really gives us another level of information, objective evidence rather than just subjective. So lastly, I'll leave you with this. Good quality sleep is vital for our overall health and well-being. So make sure you're doing everything. Eat a well-balanced diet, do some exercise, and really try your best to practice some healthy sleep habits because our bodies definitely change as you get older. So it's really important to be vigilant and be on top of those sleep habits. Thank you very much.
Thank you, Dr. Chandran. For our next speaker, first of all, I'm going to comment on his name. On the handout, his last name is given first and his first name is given last. And the same is the case on his name card over there. Khalid is his first name and Eltawil is his last name. All right, with that taken care of, let's tell you a little bit about Dr. Eltawil. He earned his bachelor's degree at the University of London and his medical degree at Cairo University. He completed residency in pulmonary critical care and sleep fellowship at the USC Medical Center in 2003. He is board certified in internal pulmonary critical care and sleep medicine. He currently serves as the medical director of the pulmonary services here at Torrance Memorial and is a part of the Torrance Memorial Physician Network. He has had a practice here in the community for over 15 years. Dr. Eltawil.
Thank you. So just a couple of disclaimers. I changed a couple of the slides, so the handout that you have may be a little bit different from what I have. And second, if any of you falls asleep, I will not take it personally. So, I was asked to talk about sleep disorders, and it's a huge subject. So I wasn't exactly sure how to address it, and I thought the best thing to do is sort of to talk to you guys about how I would look at it from a clinic perspective. We have a sleep clinic where there's two.
If you can speak a little closer to the mic, you won't have to turn it up so high and it won't ring.
Okay.
So maybe
Thank you.
can try that.
All right.
And project a little bit.
All right. So we'll talk about it from a sleep perspective. We have a sleep clinic. There's a couple of us physicians in the office. And I'll talk about the symptoms we see, the patients that come to the office, and the symptoms that we see and what patients usually complain about. The most common complaint we see is patients complaining of feeling tired. We've all felt like that. I know I felt that way many, many times. Coffee doesn't do much. We have 5 or 6 cups of coffee and we're just tired all the time. I've taken naps on my desk so many times before and just can't get going. We've all experienced that before. I've underlined the word tired here because it's really important to realize that tired is a very interesting feeling. I always tell my patients that feeling tired or fatigued is very different from feeling sleepy. There are two different sensations. Not everyone who's tired is sleepy. And it's important to realize that because if you're tired does not necessarily mean you have a sleep problem. And I get a lot of people who are tired and we end up finding that they have other things that we need to deal with. So if we look at causes of someone feeling tired, you'll notice that there's a whole laundry list of reasons. Like Dr. Chandran mentioned, a lot of the medications that people are on can cause them to feel tired. You could be anemic. Just being anemic can make you really tired. Other medical conditions, like she mentioned as well, will make you feel tired. You don't have to have a sleep problem to feel tired. I'm also a lung doctor, so a lot of my patients have work hard at breathing. A lot of COPD patients, a lot of asthma patients really work hard at breathing, and they feel tired all day long. So they're not necessarily sleepy, they're just tired. Patients who have chronic pain will feel tired all day long, or even the medications that they take for their pain will make them feel tired, and all the way at the end, you'll find the sleep disorders making them feel tired. Obviously, if you don't sleep that well, you will feel tired. Okay, better? Okay. Now, if we look from a sleep perspective, there's a lot of symptoms that we do see. This is one of my favorites. My day starts backwards. I wake up tired and I go to bed wide awake. This is a very common symptom that I hear. Some people just can't get comfortable in bed. No matter how you lie in bed, you're always uncomfortable. You lie in bed and you can't sleep. This is similar to the clock watcher. Abnormal movements, like this person is sleepwalking. This is just abnormal movements at night that I will get into a little bit later. This person also can't sleep, but he decided to do something more useful with his time. He'll get up and solve all his problems. Restless leg syndrome that Dr. Chandran mentioned, I will get into a little bit more in detail. Snoring and sleep apnea, like Dr. Chandran mentioned. So she unfortunately can't sleep because her husband is snoring really loudly. She's really annoyed, as you can tell there. And just to be fair, he also can't sleep because his wife is snoring loudly. So, yeah. All right. So, first complaint that we get in the office, someone is feeling very tired or very sleepy. So we kind of have to decide, are you really tired or are you really sleepy? So if we decide that this person is really tired, we have to go through all this list of complaints. We look at their medications. We look at their medical problems. Is there a metabolic problem going on? Are you anemic? Are you in pain? Is there an emotional problem going on? Are you depressed? Are you anxious? Are you not getting enough sleep? Maybe it is a sleep problem after all. If we decide it's a sleep problem, then we look, are you getting enough sleep? Maybe you're not getting enough sleep. If we decide it is a sleep problem, then I usually divide them into, if you are indeed sleepy, I divide them into two. Is it a problem with sleep quantity, or is it a quality problem? Are you getting enough hours in bed, or you're not getting enough hours in bed? If it is a quantity problem, just not getting the hours, I divide it into an intentional or an unintentional decreased quantity. Intentional means life got in the way. You have to get up to go to work, take your kids to school. You just don't have the time to sleep enough in bed. And we all do that. Just the other day, I got a teenager who is very, very, very tired. And unfortunately, he just goes to bed at 3 in the morning, wakes up to go to class. And he actually came in to see a doctor. He couldn't figure it out. That's the reason he's tired. But it's true. It happens. Or unintentional. That's insomnia. You're giving it the time. You just can't get to sleep. Decreased quality, that is fragmented sleep. That means you're trying to sleep, but there's something breaking up the quality of your sleep. It's sleep apnea can do that. Medical conditions like chronic pain can do that. Other medical problems, depression and anxiety, something that is just fragmenting your sleep, causing the quality to decrease. So I'm going to start by talking about sleep apnea, which is the biggest medical sleep problem that we see in the office. Sleep apnea is a condition where your breathing gets interrupted for short periods of time, 10 seconds or longer, and then usually accompanied by a drop in your oxygen levels, and then followed by an awakening. So to understand that, if you look at the anatomy of the airway, this is a side view of the airway, and this is sort of frontal view. This is the nose, this is the mouth. Between the two, this is the palate, the roof of the mouth. The front part is a bone, and then this is the soft palate between them. Again, this is the roof of the mouth right there. If you look at that, you find that the tongue fits perfectly inside the mouth. We almost think of the mouth like a suction cup holding the tongue in place. Normally, we like breathing through the nose, and air goes in very nicely inside. If we ever have allergies or a sinus infection or something like that, then we open up our mouth to breathe, and it's really uncomfortable. We don't like doing that. We prefer breathing through the nose. So even when we lie down, we still prefer breathing through the nose. Air goes in through the nose all the way down into our lungs. In sleep apnea, this is what happens. You can't breathe through the nose for whatever reason. This pathway is narrow. So you end up opening up your mouth. Air starts going in through the mouth. When that happens, the tongue is no longer supported. The bulk of the tongue is back here. The weight of the tongue is all the way to the back. So the whole area here slides back, blocks the back of the airways. So you end up having some air trying to go through the nose, but it can't. It stops back here. Some air goes to the mouth. It causes the roof of the mouth to start vibrating, and that's where the snoring sound comes from. Also, air going through the mouth dries out the mouth, so a lot of us would wake up with a very dry mouth. And because of the blockage back here, no air is moving in, so the air stops. Your oxygen level starts dropping, carbon dioxide level starts climbing. The person becomes really distressed, and eventually they wake up. So this is associated with the arousal, and because of the arousal, the oxygen and carbon dioxide changes, this puts a big strain on the heart. So the end result is sleep fragmentation, low oxygen, high carbon dioxide level. You end up getting the day sleepiness because of the disruption of the sleep and the cardiovascular complications. And that's why sleep apnea is such an important condition to address. So you suspect sleep apnea when you have loud chronic snoring, gasping and choking at night, and it's usually a bed partner that sees that. We see a lot of accidents happening from just drowsy driving and drowsy work, cognitive behavioral changes, anything that is related to not getting enough sleep at night and just daytime sleepiness. As Dr. Chandran mentioned, the treatment is either positive airway pressure, dental devices, or there are surgical options. So this is the sleep lab study, lots of wires, and you go to the sleep lab to get a study. We also do portable studies at home, which are a lot more comfortable than going to the lab. So these are the studies that we do at home and from our clinic. Oops. You can either, there are several devices. This one just goes around the chest. These can be done at home. One device just goes around the chest with a couple of wires attached to the finger. This one actually just sits on the arm. Again, a probe on the finger, a probe on the chest here. This one goes on the head with a cannula on the nose. These are good because they're at home. They're unmonitored though, so there's no monitor. Every now and then we get not that great data, but about 95% of the time we get very good data and very reliable data. Sometimes we do the lab, sometimes we do the home studies. I would say for sleep apnea, the majority of the time we do home studies now. We reserve the lab for the sort of non-sleep apnea patients for the majority of the time. So if you remember this patient where just can't move air through the back of the throat, we now have to treat that. So we treat that using CPAP, which is positive airway pressure. This is what people think about when they think of CPAP, a large mask, and this mask sits on the face, pushing air through the nose mostly. This is what we would describe as a full face mask. It covers the nose and the mouth. It looks really big and it looks uncomfortable, but believe it or not, it's not that bad. Even that one right there, it's not that bad. I've tried that one. It's not terrible. I've had people ask for this particular one by name. But there are different kinds, and she looks like she's smiling there in the picture. So they're not that bad. But the majority of the time we prescribe the nasal pillows or the nasal masks that are a lot smaller, a lot easier to put on, take off, and year after year after year, there's a lot more coming out on the market that are a lot, and every time they're just getting more and more comfortable. And these are sort of the different kinds of machines that are coming out on the market, and they actually have travel machines now, much smaller that you can take with you. They fit in the palm of your hand, almost the size of a bowling ball there. A little bit noisy, but they're really small and getting very handy to take with you on the plane. The mask fits in the nose, pushes air through the nose, and as you can see, it opens up the back of the throat there, so it reverses the pathology that happens in the back. So if you look at before and after picture, the obstruction in the back there completely gets relieved. The second kind of treatment are dental devices. There's a lot of them on the market. They all have some sort of appliance on the side to make them adjustable, so they can be adjusted. They fit on the teeth, and the idea, similar idea, to move the mandible forward to relieve the pressure on the back of the throat. And the last option is the surgical option. The surgical option, there's a number of surgeries that can be done. We usually reserve surgery till way at the end if everything else fails, because it's sort of an extreme surgery, and the success rates are very variable. But if we do decide surgery, the most common surgery is the uvulopalato-pharyngoplasty. Very long name, sorry. But it essentially removal of the last part of the roof of the mouth there. And this is what the end result looks like. So you make a big wide opening in the back of the throat. There are some people who stiffen the roof of the mouth, and that helps a lot with snoring. May or may not help with the sleep apnea, but helps a lot with the snoring. And there's a really big surgery that just advances the whole mandible forward as well. And recently, there's another device that came on the market called the Inspire. This is almost like a pacemaker placed under the skin. It senses your breathing and then sends an impulse to a muscle in the neck. Every time you breathe, it sends an impulse there to help you breathe, and you turn it on and off with a remote. So at night when you go to sleep, you just turn it on. In the morning, you turn it off without a mask or without a dental device. So this has been around for a number of years now. All right. So next thing, what if you wake up and you've slept reasonably well and you're still tired? What then? Well, I divide those into two categories. Those who wake up and they're tired but they can't sleep, and those who wake up and they're tired but if the surroundings are good, then they can go back to sleep again. For the first group, I always tell them, well, maybe you're tired but you're not sleepy. And then we have to go through that other laundry list of people who are tired. Maybe it's something else. I tell them maybe you have something causing you to be tired and sleepy. Maybe it's a sleep problem, like sleep apnea, for example, or a pain problem. Maybe that's the reason you're tired. And then maybe you're also taking a lot of coffee or you're a smoker and that's why you can't sleep. So that's how I think about it. Or maybe you have some underlying problems like depression or some underlying medical problem that is preventing you from falling back asleep. Or if you wake up in the morning and you had a good night's sleep, but you're very sleepy and can go back to sleep again, well, maybe your sleep was really fragmented, like just we had this long talk about sleep apnea. Maybe that's what's going on. Maybe you have another sleep condition. Maybe you're one of those people who needs more sleep. Dr. Chandran just mentioned that 7 to 9 hours is an average sleep. I have patients in my clinic who need 10 hours, 11 hours. Maybe you're one of those people. Maybe you have a circadian rhythm problem. I'm going to talk about that in a second. Some people have other conditions like narcolepsy. There are other medical conditions or sleep conditions that we will just need to discuss it and talk about. Some people take medications that make them sleepy during the day. Some sleep aids or some sleep medications last longer than they should and linger during the day. Some medical conditions, depression, people with depression just sleep all day long. This is a big one, people who can't sleep. People who can't sleep are sometimes a problem. You go to bed and you can't sleep, and it becomes very frustrating. But there's a lot of reasons for that. Circadian rhythm are a common one. We see that a lot. Dr. Chandran mentioned the clock, and that's actually an important one to know, that there is such a thing as a clock in our brain, and it tells us when to go to sleep and when to wake up. So the way I describe it is there are two forces or two chemistries working against each other at any given time. Something telling us to go to sleep, something telling us to wake up. And the balance of those two determines whether we wake up or sleep at any given time. So during the daytime, something waking us up, something making us go to sleep. And because the force waking us up is stronger, we're awake. But if you were to take a sleeping pill during the day, you may fall asleep. And at night, because the force putting us to sleep is greater, we fall asleep. But if you were to drink a cup of coffee, you may wake up. So that's sort of what determines if we're awake or asleep. So we have a special sleep phase that we sleep. So if you look at the normal sleep phase of this particular person, this person goes to bed around 11 o'clock and wakes up around 7 or 8. So this is a normal sleep phase. If you look at this person who has a delayed sleep phase, this person wants to go to bed at 4 and wants to wake up at noon. Imagine if he went to bed at 11 like this person. He would lie in bed for 5 hours and can't go to sleep. And then he would eventually fall asleep at 4 and sleep a normal sleep until noon. If he went to bed at midnight, he will not be able to sleep until 4. He would wake up at 8 and very tired. So he would fit that typical, I go to bed wide awake and I wake up very tired. An exact opposite will be this guy who falls asleep at 6 and wakes up at midnight. So these are sleep phases that we work with, and we can adjust them with certain medications and adjusting their sleep phase and their sleep cycle and so forth. There are some other rarer ones, like people who have really irregular patterns and some people who just don't follow a clock. These are a little bit more rare, but we do see them every now and then. Another cause for people who can't go to sleep are restless leg that Dr. Chandran talks about. These people have just a really horrible sensation in their legs. It's very difficult to describe. It's described as a creepy, crawly. Some people describe it as pain. Some people just fidgety legs. It's sometimes really difficult to describe. Some people just can't keep their legs still. Usually happens during period of rest, just before you go to sleep. But sometimes you go to the movie theater and same thing happens. You just can't keep your legs still. It's relieved by movement. So these people would get up and move around and their symptoms go away. Associated with iron deficiency sometimes, kidney diseases, pregnancy. There are some medications to take care of it. Some home remedies help, warm showers, stretching. A lot of people tell me they get a bar of soap and put it under the sheets and it seems to help. And I actually found a picture online to that extent. I was going to put it, but I didn't think it would be a good idea. I don't know why, but it seems to help. Well, there is such a thing. And then other causes. If you notice that these lists is the same list every single time, it keeps repeating, and you always look, and that's what Dr. Chandran mentioned as well. Pain, discomfort, work of breathing, shortness of breath, medications, caffeine, smoking, emotional distress, depression, and anxiety. That list always recurs because that's always what interferes with our sleep. As we grow older, these things happen to all of us. How many of us has thought that? I have. Yeah, I have exactly 7 hours, 23 minutes, and 48 seconds of sleep. Now, Now, the moment that thought enters your head, it is impossible to go to sleep, right? So, and that's one of those behaviors that you need to work on when you're trying to go to sleep. And that is part of the cognitive behavioral therapy that Dr. Chandran was talking about when you treat insomnia. You lie down to fall asleep, and your brain starts thinking, your brain starts wandering. And the moment something like this goes on, it's impossible to fall asleep. So you need to, and the reason is, it's not because you can't sleep, it's because you're very stressed and anxious. All right, what about if you can't stay asleep or you wake up too early? Well, guess what? It's the same list. Pain, discomfort, you're short of breath, medications, and anxiety, depression, stress, poor sleep hygiene, or insomnia. It's the same list that's also disrupting your sleep in the middle of the night. I'm not going to talk much about insomnia since we've talked about it a lot, but I usually divide it into short term, which is 3 months or less. This short-term insomnia is usually an easy one to treat because it's usually caused by a stressor. Most of the time, the stressor is relieved, and the insomnia usually corrects itself. You get a new job, or you lose a job, you meet someone, or you lose someone. Usually, that stressor goes away, and you get better. Sometimes you need a little bit of help, maybe a short-term sleeping pill. Usually it goes away. The long-term insomnia, which is more than a month, that is a little bit more difficult to treat, and that is usually the one that necessitates the treatment with cognitive behavioral therapy and so forth. As Dr. Chandran mentioned, sleep hygiene is very important. Behavioral therapy that she mentioned as well, and medications, and generally speaking, it's usually a combined approach of all these together. That is part of the behavioral therapy. So she mentioned about the naps or sleep being a bank. This is a very good example of it being a bank. If you're going to take a nap, you have to understand that that nap is part of your sleep at night. So if you're going to take a nap, that's part of your sleep, and you have to understand it's going to take away from your sleep at night. I think getting close to the end here, abnormal movements at night, REM sleep disorder, I see it very frequently. This is an interesting condition where normally when we dream, we have a tendency to want to act out our dreams, but during the period of our dreams, we lose any ability to move. So during REM sleep, which is the period of where we do most of our dreaming, we lose the ability to move. And that's normal for all of us. In some people, we still maintain that ability to move. So we end up acting out our dreams. So this person here is dreaming that he's fighting, and he ends up fighting. So it's dangerous in that he can fall out of bed, he can injure himself with a sharp edge right next to the bed there, or he can injure a bed partner, which happens frequently. There's an association of REM sleep disorder with some neurodegenerative disorders like Parkinson's and so forth. So if you see a spouse who is acting up in bed, yelling, screaming, fighting, falling out of bed frequently, it is something you should bring to see a physician about. He may be fighting because it's intentional. Maybe he does want to hit his partner. Maybe. But generally speaking, it's not. Other things that we see, seizures, sleepwalking, talking, eating, nightmares, night terrors, we see them every now and then as well. So you should talk to your doctor if you feel sleepy. Even after a good night's sleep and you're still tired, you should come see a doctor. If you fall asleep watching TV, there's a problem there. If you wake up gasping, or someone tells you wake up gasping, if you're snoring loudly, keeping your bed partner awake, if you have a hard time falling asleep, or you wake up too early, if you wake up many times in the middle of the night, uncomfortable, restless sensation in the legs, or any of those abnormal movements at night. Thank you.
Thank you, Dr. Eltawil. We'll now have a 5 to 10 minute break, during which time you can submit written questions to be answered after the break. Members of the committee will be passing around, collecting your questions and passing out paper and pencils. Thank you. All right, let's try to get started here. First question for either one of our speakers. What is sleep hygiene anyway?
All right. Sleep hygiene, I'd call it, definition is kind of more sleep tips, sleep rules, how to keep clean sleep, just the same as personal hygiene. You wash yourself, you brush your teeth. Sleep hygiene is generally, this is the practice that I do before I sleep, a routine. So I generally say the term keep good sleep hygiene, just as you brush your teeth and floss. These are the general rules that I have. Keep a cool environment, keep it quiet, avoid the lights, that kind of stuff falls into the sleep hygiene criteria.
Okay, we have several questions regarding medications that I'll try to consolidate here to save a little bit of time. Questions about or actually I guess it should be phrased, please comment on Tylenol PM, melatonin, and Benadryl, or a sleeping pill. Any comments that you would care to make?
So Tylenol PM is a combination of Tylenol and Benadryl, essentially. Benadryl, or diphenhydramine, is an antihistamine, and it does have sedating qualities if taken at night. I'm not sure what the question is relating to that. It does make you sleepy. It has other effects to it, that it has a little bit of a drying quality. People take it when they're congested, so if you have a sinus issue or so forth, it helps with that. It does have other problems with it, so I wouldn't take it routinely, as it does have urine issues and so forth. It can make you stop urinating, particularly in men and so forth. So I would be taking cautiously. I wouldn't just take it every day, but it does have some sedating qualities. Melatonin is a very interesting medication. It has a little bit of a sedating quality, but what it really does is that it helps the clock in the brain. It tells the brain what time it is. So it goes in there and it tells the brain it's nighttime, essentially. So it tells the brain it's nighttime, do what you do at night, which is essentially go to sleep. So it's a good medication for people who have circadian rhythm problems and so forth. So it helps you regulate your nighttime sleep. Side effects on profile is very minimal, so it's a fairly safe medicine to take. The problem with melatonin is that there is really no perfect dose, and it's not really regulated that much, so you don't really know what the dose you're getting on the market is. Some people take 1 milligram, some people take 10 milligrams, and there's no perfect or right dose out there.
The question here, if you have sleep apnea, can it just go away by itself or without using CPAP? Or do you have to do something in order to make it go away?
So sleep apnea is a chronic condition. It tends to get worse as you get older, generally just because the tissues in the back of the throat get saggier. And in general, it doesn't just go away on its own. It requires chronic treatment, just like taking medication for blood pressure. There's 3 main treatments. Positive pressure therapy is the most efficacious and least invasive, so CPAP. Number 2, oral appliance. And number 3 is surgical options. And surgical options are, you know, kind of on the back burner because it's more invasive and the it's variable on how efficacious it is.
I'll just add to that sleep apnea is a chronic problem, and it requires daily treatment just like blood pressure. It is a mechanical problem, just like I showed in the picture, so it needs to be treated mechanically. There are situations where if you somehow or the other change the anatomy of this airway, then the sleep apnea can go away. So exactly. So some surgery can make it go away because you're changing the anatomy of the airway, but also there is a big relationship with sleep apnea and weight. It's estimated that for every 10% body weight change, there is a change in your sleep apnea by about 37%. It's a huge relationship. I've had many patients actually lose so much weight that their sleep apnea went away. So that is probably the one situation where it can go away without treatment.
A couple more medication questions that escaped my notice originally. What are benzos and non-benzos? And I don't know, I sort of infer from this that this is some form of Ambien. And what dosage would you recommend? Are benzos and non-benzos one or the other some form of Ambien?
So Ambien is classified as a non-benzo, but it is a scheduled drug. I do not recommend chronic Ambien usage without trying to work on the behaviors and going through cognitive behavioral therapy. Doses, vary. I always start at the lowest. The lowest dose is always better. Benzos are another class of medication, such as, I guess you'd say, Xanax or Ativan. I definitely try to steer away from those. They are used at times, but I try to steer away from it. Again, for insomnia, I try to focus more on behavioral therapy rather than chronic medication because it can be a kind of a vicious cycle with the medications.
Here's a question on yawning. Does yawning indicate tiredness or sleepiness? What is it anyway? What causes it?
Excellent question. I'm kidding. Actually, yeah, I don't know that I know a good answer for that. We yawn when we are tired, and we yawn when we are sleepy. I think more when we are sleepy. Why we yawn, I don't know that I know an answer. I don't think anyone knows the answer. There are certain things that we don't know yet, and if anyone finds an answer, please let me know.
Can acid reflux medications contribute to sleeping problems?
Yes, absolutely. And it's actually a two-way problem. Did you say acid reflux medications?
Yes.
Acid reflux can cause sleep issues. I'm not sure of acid reflux medications. Do you know?
I think treating acid reflux can be worse in patients with sleep apnea. And I think treating acid reflux will help sleep. I don't think the medications, I'm not aware of the medications causing sleep problems.
Exactly.
Okay, a similar question regarding Flexeril. Could that have any effect on sleep apnea?
Yes.
Maybe you want to explain to people like me what Flexeril is as well.
So Flexeril is a muscle relaxant, and any medication that relaxes or sedates will loosen or decreases the muscle tone in the body, including all the muscles in the head and neck, and that decreases the likelihood of the airways keep staying open, and that increases the likelihood of sleep apnea being worse. And that also includes alcohol.
Is there, or can you explain any connection between sleep apnea and frequent nighttime urination?
Yes. Yes, with sleep apnea, there is usually an increased incidence of nighttime urination. And usually when you treat the sleep apnea, the nighttime urination improves. That being said, it is not the only reason for increased nighttime urination. People who do urinate frequently at night, they may find their urination improve, but may not necessarily go away all the way.
Here's a question regarding sleep efficiency. If a person has low sleep efficiency, how can that be improved to get it closer to normal?
So my recommendation is sleep efficiency is the time slept over the time in bed. So the first thing I'd say is spend less time in bed if you're not sleeping. Take away the kind of bottom factor to increase the sleep efficiency. And then the number two thing, kind of as I talked about, is really work on sleep hygiene. Make sure you've resolved any kind of organic issue, such as sleep apnea, because that could be causing frequent awakenings and causing yourself to wake up. So work on having good habits, going to bed at the same time, not having caffeine, not smoking, all of that stuff we talked about. But also make sure you diagnose any underlying issue and go through any medications. But the big thing is don't take these naps, and also don't spend so much time in bed to worrying about sleep and sitting in bed not sleeping. Go out of the room and go somewhere else to increase the sleep efficacy.
Okay, here is someone who has no problem falling asleep, often wakes up too early and can't get back to sleep. Currently is taking, I'm having trouble reading this, Deseril or some similar name, which is helping. Would there be any problem with taking it long term? Or do you recognize the name of the medication? It looks like DESYREL or something similar.
So generally, I am not a big fan of taking medications long term, and especially if it's taken in the middle of the night. If you remember when we looked at, when I was going through my slides, and you had that repetitive slide showing why you're having trouble falling asleep, why you're having trouble staying asleep or waking up early, there's a lot of other conditions causing that, and generally I like to go through and find out why the reason is that this is happening. So I would advise that you probably see a physician and try to find out the reason why you're waking up in the middle of the night and why you're needing to take a medicine in the middle of the night. More than likely you will be able to not have to take that medicine.
Okay, we have, count them, 10 questions related to something, the acronym OSA. That's quite a few. Can you first of all tell us what OSA is and then discuss it briefly?
OSA is obstructive sleep apnea, and that was what I discussed for most of my lecture.
Okay. I have sleep apnea when I sleep face up or on my side. Are there other positions such as a wedge pillow that might help? Does the sleeping position affect the sleep apnea?
There are definitely cases of positional sleep apnea. Sleeping supine, which is on your back, is where, imagine your tongue gets more relaxed and it can fall to the back of your throat. That can worsen sleep apnea. Wedge pillows are kind of, I don't think there's any data. I have recommended them to certain people to also help them if they have positional sleep apnea, and have them help them sleep upright a little bit. And yeah, I've had some relief. Some patients say it's okay, but you know, a lot of this stuff, there's no real data behind it. And I hate to recommend this to patients, you know, all the time, knowing that there's no real data. Patients put their money out there and they try to go out and get, you know, all these things, the lavender oil and the vibrating pillow and this and all this stuff. It's very gimmicky out there. The wedge pillow can help sometimes, helps with acid reflux a lot, can help some people with sleep apnea, but it's not for sure like a sure efficacious thing.
Here's an interesting question. Can lack of sleep kill brain cells?
I don't think so.
Okay, good. Why is it a problem if you fall asleep watching TV? There's two people want to know the answer to that.
So I'm going to try to be as politically correct as possible because my wife may be watching this. I would say it is not a problem if it does not affect your sleep at night. It is only a problem if your sleep is disturbed. So if you can watch TV and fall asleep and have a good night's sleep at night and you do not have other sleep issues like sleep apnea, by all means go for it. That would what I would say. However, if you fall asleep if you fall asleep in front of the TV, then get up and go to bed and have a hard time falling asleep, or if you fall asleep watching TV because you have a sleep condition like sleep apnea, then you definitely need to change that.
Question here about REM sleep. I think it might not hurt to explain that REM stands for, I believe, rapid eye movement, and that's apparently good. Anyway, how do you get more of it?
So REM sleep, rapid eye movement sleep, is kind of our deeper sleep. It tends to happen a lot of times later in the morning. It can happen anytime at night, but it happens a lot more later in the early morning hours. Generally, it's the time when your airways are more collapsing. You'll usually find that on a sleep study, you'll see patients sometimes have more breathing events or episodes where we see their airway collapsing. How do we get more of it? Treat any underlying condition that's stopping you from going into REM. So if you're taking a medicine that can have more stimulation activities that's causing you to not go into REM, then maybe consider getting off that medicine. If you're drinking alcohol that's causing you to wake up, then get off the alcohol. So it kind of goes with the keeping the good sleep hygiene, checking your medications, making sure there's no underlying sleep apnea, because that sleep apnea will cause your brain to wake up and say, hey, I'm not breathing, and cause you to have less REM. So kind of treating all of those underlying conditions will cause you to have more REM sleep, or as much as you can physiologically as your body is going to get.
Okay, I think we may have answered this, but I'll ask it anyway, and you can say we've answered it if we have. Can lack of sleep be bad for your health besides the discomfort and the fatigue that you have with it?
Yes, absolutely. Lack of sleep can affect a lot of things other than just discomfort and fatigue. Lack of sleep is associated with a lot of the metabolic disturbances, including poor sugar control, cardiovascular implications, blood pressure issues, cognitive changes, weight gain. It's harder to lose weight if you don't get enough sleep. It is associated with increased car accidents, work-related injuries. It is definitely bad for your health in general.
This is related to what we've been talking about, but not directly sleep-related. We've been talking about frequent urination. The question is, should I drink less or drink at certain times of the day, or how does one in general attack the problem of frequent urination?
I would go get a full physician evaluation. There's many causes of frequent urination at night. Prostate problems, diabetes problems, obstructive sleep apnea is one of the many. So it's important to look at the picture as a whole. If there is underlying sleep apnea, get the sleep apnea treated. Of course, drinking less at night is helpful. That's what I recommend for my kids when I'm trying to potty train them at night. So following that same principle, it makes sense. But I definitely would seek a full evaluation because obstructive sleep apnea can cause increased urination, but that doesn't mean it's going to solve it. There may be a prostate problem or also diabetes causing things like that. So definitely take a look at the picture.
Is getting up 3 times per night to urinate too often?
I would think so. Ideally, one shouldn't get up to urinate at all.
Comment on antihistamines related to sleep problems. Is there a relation?
Antihistamines are used frequently as a sleep aid. They're probably one of the common ones on the market. We see Benadryl, Tylenol PM, Advil PM, Simply Sleep. There's a lot of them on the market. They're used very frequently. They do have sort of side effects on their own. They can be used sparingly, but I don't usually advise them to be used all the time. They are frequently used generally as cold medicines, and they are sedating if used at night.
Here's a question regarding dry mouth and runny nose with a CPAP machine. How does one handle this? I guess you try a different mask or something, or that's my non-educated guess.
So dry mouth, runny nose, these are frequent complaints with CPAP. I find that a lot of people go on CPAP and they say, this has saved my life. And then there's a good segment of them that say, I have this issue, I have that issue, dry mouth. There is a heated humidifier in these machines, so maybe turning up the heated humidification. Runny nose, sometimes I've used a little Flonase temporarily to help with the runny nose, help people tolerate it a little better. Try changing the mask to a more comfortable mask, or even trying a full face mask, being open to it. Those are kind of, but that's kind of when you come to the sleep clinic. There should be a lot of frequent check-ins with a sleep doctor because we really want to make sure people are compliant. And that requires a little bit of fine-tuning of the CPAP and hand-holding through that process.
If you don't have good sleep habits and you stay up late and so forth, could you have symptoms like narcolepsy during the day?
Narcolepsy is a condition where you feel very sleepy during the day. So sleep disorders are the most common symptoms of all sleep disorder is you feel tired. So they all sort of look alike. So if you have poor sleep habits, you will feel sleepy. If you have narcolepsy, you will feel sleepy as well. So yes, you could have similar symptoms. Narcolepsy does have very specific symptoms, though, that we are able to ask, and to diagnose narcolepsy, you have to have a specific finding on a sleep study.
There's a question about whether a certain breast cancer medication might make insomnia worse. I'm having trouble reading it. Arimidex or some similar name. It's an estrogen blocker.
Hormonal changes definitely affect sleep. So there is a possibility. However, given the history of breast cancer, I wouldn't recommend going off that hormonal medication unless under the direction of an oncologist. But yes, hormonal changes, since that is an estrogen blocking medicine, it can definitely change sleep habits. But like I said, I wouldn't go off of it given that history.
All right, here's a question regarding a sleep study. Shouldn't the study be done in your normal position rather than being told to sleep in some other position?
That is a very good question, and that is why a lot of studies now are being done at home. That being said, we do need to do some studies in the sleep lab because a lot of the wires that Dr. Chandran showed in her study, in her slides, just cannot be done at home. Having all these wires and monitors cannot be accommodated at home. But if we are looking for sleep apnea, which is the majority of the patients that we look for, doing a home study in your normal position at home is very feasible, and we do that from our office.
This may be, appears to be a question about a home remedy. Do magnesium baths help one to relax and fall asleep? Have you ever heard of that?
I've definitely heard of magnesium as a muscle relaxant. I've heard of patients getting symptomatic relief. Again, there's no set data on this kind of stuff. There's a lot of different things that you can find in the market to help sleep. I've had people specifically tell me about magnesium baths, so if it works, go ahead and try it. I don't think there's any harm to it, but there's no set data.
Does tryptophan help? That's the stuff that they put in turkeys, I guess. It's an amino acid also.
I don't think there's set data. Tryptophan is a hormone that can induce sleep. It's actually a real thing. So yeah, are you talking about through food or for a supplement?
It doesn't say.
Okay, well, I'm an advocate for just eating some turkey.
Why can't people remember their dreams afterwards?
So, sleep is a very strong amnestic, I guess that's the word I'm looking for. It makes you forget. If you are able to sleep for a period of time, you will forget anything that happened before that period of time. So we all dream, but if you wake up after a period of time, after that dream has happened, you will not remember that dream. If you wake up within a very short period of that dream or in the middle of the dream, you will remember the dream. So the people who remember their dreams either woke up in the middle of their dream or very shortly after the dream. So they remember it. The people who do not remember it just either woke up way after it or they had a long time pass between the dream and the awakening.
Here we have someone who has multiple problems on the list. Where to begin before going to the doctor? Apparently reluctant to ask the doctor about this or not getting a satisfactory response from the doctor. If you're trying to figure it out yourself, what's the first thing you should do? Go to a different doctor, perhaps? I don't know. You have multiple problems. How should one begin to get better sleep? What is the one thing to change first before going to the doctor?
So the one thing that I would focus on is make sure you are clear on all those sleep hygiene things that we talked about. Not being on your cell phone, not having the computer, keeping the lights dim, try less stimulation, making sure you're not taking naps. So that's kind of a easy self thing that you can control yourself. And then maybe if this problem persists through the sleep hygiene, then seek the help of a sleep specialist. Sometimes they are better at honing in, taking a step back, and looking at the overall picture.
Can a traumatic brain injury affect sleep? I would assume that's yes.
Absolutely, yes. In multiple ways, it can cause sleep apnea and it can cause significant insomnia.
This person has been diagnosed with psychophysiological insomnia. What next? As in, what is the next step?
Next step is to work on the sleep hygiene and really get into an integrated cognitive behavioral therapy program. You may need a little bit of help with medications, but focus on sleep restriction, maybe keep a sleep diary, work closely. I mean, I'm talking about when I was at Stanford, they would have these meetings and they would restrict people, slowly take their sleep down by 15 minutes a week, and then eventually increase it later on. So there's someone who's closely following, reviewing these sleep diaries, really get into a very thorough cognitive behavioral therapy program.
Here is someone who is so tired he can't keep his or her eyes open, and as soon as they go to bed is wide awake and then is very tired and can't go back to sleep. What should be done? See your doctor?
So yeah, I mean, this is this is a long discussion, and he does need to see his doctor. But one of the things that is interesting is the relationship between sleep and your bed, or a person's bed, is a very strong one. So if you could, for people who sleep well, you could be wide awake, and if the time is right and you go into bed, you get this very nice, warm, cuddly feeling of going to sleep, and you fall asleep right away. People who have insomnia, though, tell me that they're really tired and really sleepy, and the moment they enter the bed, it's like someone turned a light switch on. They're wide awake. And that is that relationship with the bed that needs to be worked on. And that's what Dr. Chandran is talking about with the sleep habits and so forth. So that's where all that slide about changing your sleep habits and changing your time needs to be worked on. So yes, a person like that does need to see their doctor.
Okay. Here is someone who is disturbed by noises from the neighbor, frequent urination in the night. What can be done besides moving or giving the neighbor diapers?
I'm not sure how to solve that problem with the neighbor and the urinating. Well, the neighbor's going to urinate. You could educate them and tell them to go see their physician about their urination in the middle of the night. But that would be an awkward conversation.
It certainly would. I'm glad my neighbors are not like that.
Yeah, so I'm sorry. Besides moving, I don't have much else to offer.
Here's a question about a light metronome system that is supposed to, I guess, be relaxing. It's DODOW. Have you heard of it?
I haven't heard about this specific one, but we do use light therapy a lot to adjust your sleep pattern, particularly in people who have circadian rhythm problems.
Okay, we're approaching the end here. Have you heard of a sleep program called Shut Eye? The I is spelled letter I rather than EYE.
Unfortunately, I haven't heard of it. But you know, like I said, there's a lot of stuff. I'm not putting down this program, and if it works for you, go for it. There's a lot of like sound machines and vibrating this and things that, and you could spend thousands of dollars on this stuff. Just beware that there's not a lot of evidence on a lot of this stuff. But I do encourage things. If it works, please go try that app or try that pillow or whatever helps you sleep at night.
Okay, and our last question is from someone with an anxiety disorder, taking melatonin, can't stay sleeping, wakes up and goes to the bathroom, can't sleep anymore. What can be done?
So I think the beginning part of that question is where the key is. This person has an anxiety disorder, and that's what needs to be addressed. So the key is correcting that anxiety disorder. I always describe that as a person who falls down and breaks a hip and is in so much pain that they can't sleep. The treatment at that point is not a sleeping pill. The treatment is correcting the hip fracture. And once the hip is corrected, the person will sleep. The same problem here. You address the anxiety, and then the sleep will correct itself.
Okay, that concludes our questions. Tune in again next month when the program will deal with the future in genetics. That will be the third Wednesday of the month, Wednesday, October 17th. Hope to see you here then. Thank you very much.